Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. Your hardest times often lead to greatest moments of your life. Keep going. Tough situations build strong people in the end. Assalamu alaikum everyone. My name is Dr. Sadia Rafiq and under the supervision of Professor Saira Afzal, today my topic of presentation is rheumatic fever. Learning outlines include the introduction to rheumatic fevers, problem statement, etiology, pathogenesis, sign and symptoms, treatment, laws of prevention, recent updates, and multiple choice questions. Learning outcome. At the end of this presentation, participants would be able to describe rheumatic fever, its epidemiological factors, sign and symptoms, complications, treatment and prevention and control. Problem statement. The global incidence of acute rheumatic fever. In developing countries, the magnitude of acute rheumatic fever is enormous. Recent estimates suggest that 33.4 million people worldwide have rheumatic heart disease and that 3 lakh to 5 lakh new cases of rheumatic fever, approximately 60% of whom will develop rheumatic heart disease occur annually, with 2,30,000 deaths resulting from its complications. Almost all of this toll appears in the developing world. In Pakistan, the prevalence of rheumatic heart disease in Rahim Khan sub-district is 5.7 in 1,000. Assuming that this is a rate of rheumatic heart disease throughout the rural population of Pakistan, which is 88 million, there are more than 5 lakh patients with rheumatic heart disease in rural Pakistan. Introduction. Rheumatic fever, a delayed autoimmune reaction in genetically predisposed individuals to group A, beta hemolytic streptococcal GBHS pharyngitis, characterized by inflammation of several tissues that give rise to typical clinical characteristics, including carditis/valvulitis, arthritis, chorea, erythema marginatum, and subcutaneous nodules. Residual damage only in the heart. Latent period of 3 weeks, which extend from 1 to 5 weeks between GBHS infection and acute rheumatic fever, and it includes 3 to 6% of any population. Etiology. Acute rheumatic fever is a systematic disease of childhood, often recurrent, which follows group A beta hemolytic streptococcal infection. It is delayed non-suppurative sequelae to upper respiratory tract infection with GBH streptococci. It is a diffuse inflammatory disease of connective tissue, primarily involving heart, blood vessels, joint, subcutaneous tissues, and CNS. Epidemiology. Ages 5 to 15 years are most susceptible, rare in less than 3 years. Girls are more than boys, common in third world countries. Environmental factors include the overcrowding, poor sanitation, and poverty. Incidence more during fall, winter, and early spring. Pathogenesis. Delayed immune response to infection with group A beta hemolytic streptococci. After a latent period of 1 to 3 weeks, antibody-induced immunological damage occurred to heart valves, joints, subcutaneous tissue, and basal ganglia of brain. Group A beta hemolytic streptococcus strain that produces rheumatic fever M type 1, 3, 5, 6, 18, and 24. Pharyngitis produced by GBHS can lead to acute rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis. In the skin, infections produced by GBHS leads to post-streptococcal glomerulonephritis only. It will not result in rheumatic fever or carditis. Features suggestive of GBH infections include the patient would be in 5 to 15 years of age, presentation in the winter or early spring, fever, headache, sudden onset of sore throat, nausea, vomiting, and abdominal pain, pain with swallowing, beefy, swollen radula, soft palate petechiae, which is also donor lesions, tender and large interior cervical nodes, and tonsilopharyngeal erythema next to it. Now you can see the redness and swelling of throat and tonsils, beefy, swollen, red, soft palate donor lesions, then erythema exudates. These are all the suggestive features. Now you can see that the streptococcal throat infection leads to immunological response, rheumatic fever 10 to 14 days later, and it affects the joints, heart, skin, and nervous system. As far as the pathophysiology is concerned, causative agent group A beta hemolytic streptococci leads to if untreated strep throat infection leads to fever. All layers of the heart and the mitral inflamed. Rheumatic fever, all layers of the heart and the mitral valve becomes inflamed, vegetation forms, valvular regurgitation and stenosis, and the leads to heart failure. As far as the clinical manifestations of acute rheumatic fevers are concerned, you can see leads to these are the months: polyarthritis, carditis, and erythema marginatum. And this is the chorea, and it is the subcutaneous nodule. You can see that the magnitude and their duration. Starting with carditis, incidence varies from 50 to 60%. The clinical diagnosis of carditis in an index attack of rheumatic fever is based on presence of significant murmur, mitral regurg, aortic regurg, pericardial rub, unexplained cardiomegaly with congestive heart failure. It is common in young, and 80% of the patients develop it within first 2 weeks of rheumatic fever. Endocarditis and valvulitis, always associated with the murmur of valvulitis, and universal finding in rheumatic carditis, where the presence of pericarditis or myocarditis is variable. Valve involvement, 92 to 95% mitral valve involvement, and 70 to 75 only isolated. This valve involvement at 20 to 25 aortic valve involvement with 5 to 8% isolated involvement. Then comes the pericarditis. It is 60 to 15% of rheumatic fever diagnosed with typical pain and friction rub, always associated with rheumatic. Valvulitis may be associated with normal ECG, may be associated with effusion, but rarely causes constriction tamponade. Its presence denotes severe carditis. Polyarthritis, 66 to 75% of the patients. Most common and most earliest manifestation typically involves large joints of knee, ankle, wrist, and elbow. Involved joints are hot, red, swollen, and tender, migratory in nature, not deforming, a dramatic response to small dose of salicylates. The next is subcutaneous nodules. These are rare, 22 to 20%, freely mobile, painless, 0.5 to 2 centimeters in diameter, occur in crops over bony promises or extensor tensors. Common locations are elbow, wrist, knee, ankle, and Achilles tendon. Erythema marginatum, 3 to 15%. Erythematous, serpiginous macular lesions with pale center that are not pruritic. Multiple lesions primarily on the trunk or proximal extremities, rarely on distal extremities, and never on face. It occurs only in the course of rheumatic fever. Erythema marginatum, non-painful, non-pruritic blanches of pressure, accentuated by warming the skin, not influenced by anti-inflammatory therapy. It is associated with carditis. Nodules and marginatum can occur simultaneously. It is also seen in sepsis, drug reaction, and glomerulonephritis. Chorea, Sydenham chorea, Saint Vitus dance, 5 to 36% of acute rheumatic fever. Most common in females, rare more than 20 years, isolated frequently, such as neurological behavior disorder, emotional lability, incoordination, poor school performance, uncontrolled movements and facial grimacing, exacerbated by stress and disappear with sleep, and seen occasionally unilateral. So this is, you can see the picture of Sydenham's chorea, involuntary muscular movements. Minor manifestations include the arthralgia, fever, epistaxis, and abdominal pain. Evolution of Jones criteria. Original Jones criteria was generated in 1944. It has different major manifestations and minor manifestation. It includes all the major and minor, and later on it was revised and updated in 1992 with the major manifestation was carditis, polyarthritis, chorea, subcutaneous nodules, and erythema marginatum. And the minor manifestations were fever, arthralgia, prolonged peak interval, lab findings, elevated acute phase, reactors, increase ESN and CRP. So you can see the rheumatic fever criteria. Nominac is Jones Cafe Paul. Major criteria includes the joint involvement. O looks for the heart myocarditis, nodule, subcutaneous erythema marginatum, and Sydenham's chorea. The minor criteria: Cafe, CRP increase, arthralgia, fever, elevated ESR, and pause for prolonged peer interval, emesis of rheumatism, and leukocytosis. The diagnosis includes that throat cultures growing GBHS or elevated interstitial O titers, plus two major criteria, any of the two, or one major or two minor criteria for the diagnosis of rheumatic fever. Again, a picture, the abbreviation from his name, Jones for joints, carditis, nodules, erythema marginatum, and as for Sydenham chorea. Again, the major criteria and the minor criteria, you can see the migratory polyarthritis with 75%, carditis is 45 to 70%. And remaining percentage erythema marginatum 2 to 10%, and skin nodules, etc. Again, summarizing the whole acute rheumatic fever, rheumatic heart disease, along with the Jones criteria. The lab diagnosis of acute rheumatic fever, no gold standard diagnostic technique, throat culture sensitivity, initially considered gold standard for diagnosis of streptococcal infections, but it has limitations, difficult to differentiate a carrier from active infection, and 1/3 of rheumatic fever has no history of preceding pharyngeal infection and delay in getting culture report. Lab diagnosis, rapid antigen test from throat swabs, specificity 95% and sensitivity 60 to 90%. Then the streptococcal antibody test, which includes anti-streptolysine, ASO, anti-DNase, B, anti-hydrogenase H, and streptozyme assays, in which all the antibodies, anti-streptolysine O is most important, because its titer increases as almost double the ASO titers after a few weeks, you can say. And then this initial, when there's infection of rheumatic, there's an increase in the peak of the ASO titers, but after sometimes it has different variable responses. The hash line indicates the subsequent variable responses. It may go straight, it may decline, or may decline very much. Echocardiography advantages in rheumatic fever are superior sensitivity in detecting rheumatic carditis, avoid misdiagnosis, and disadvantages are overdiagnosing of physiological valvular regurgitation as an organic dysfunction. Echocardiography facilities are not widely available, and ability to detect the recurrence of subclinical carditis is not clear. The endomyocardial biopsy, their Aschoff nodules or histologic aggregate considered diagnostic of rheumatic myocarditis. Sensitivity is 43% and specificity is 100%. Myocyte degeneration usually without lymphocyte infiltration, frequently without Aschoff's nodule, and doesn't provide additional diagnostic information, and it is not recommended. So the joint manifestation and elevated CRP and SR with or without fever leads to echocardiography within 12 weeks. If pathological mitral or aortic regurgitation with or without morphological changes suggestive of acute carditis, diagnose acute rheumatic fever. And if there's no cardiac involvement or echocardiogram performed within 12 weeks of the index illness, then diagnose ARF if 2015 Jones criteria is fulfilled. It means 2 major or 1 major, 2 minor. Moving towards the levels of prevention. Primordial prevention includes a range of improvements to living conditions that reduce poverty and overcrowding in population at risk of acute renal failure and rheumatic fever and rheumatic heart disease. There have been dramatic reductions in the rates of ARF and RHD in population that have experienced improvements in socioeconomic and environmental conditions. So the primordial prevention includes improvement in socioeconomic status, prevention of overcrowding, improving nutritional status, availability of prompt medical care, public education regarding it. Primary prevention of rheumatic fever, group A, streptococcus, GAS infection of the pharynx are the precipitating cause of rheumatic fever. Proper diagnosis and adequate antibiotic treatment of gas infection can prevent acute rheumatic fever in most cases. You can see the treatment, primary prevention of rheumatic fever. This is the agent, which is benzathine, penicillin G. Dose is mentioned, intramuscular is the route, and the duration is once. And if we are to give the penicillin 5, then in children, it is given orally for 10 days. And those people who are allergic to penicillin erythromycin, it is also given. And the thing which is to remember, its duration is for 10 days for the oral medication. And if you are giving intramuscular, it is only given once. Otherwise, it is always given for 10 days. Again, the treatment of rheumatic fever, you can see penicillin G or VSB given. And if it is injectable, that's single dose. And if it is oral, then it is given for 10 days. Then for the arthritis, aspirin is given. For carditis, steroids, prednisolone is given to treat the symptoms. Post-treatment throat cultures 2 to 7 days after completion of therapy are indicated if patient remains symptomatic, whose symptoms recur, or patient who have rheumatic fever and are therefore at unusually high risk for recurrence. And the treatment failure. A second course of therapy is asymptomatic individuals should be considered only for those with previous rheumatic fever themselves or in members of their families. Treatment required if symptomatic. Treatment of carriers. Chronic streptococcal carriers are defined as individuals with positive throat cultures for gas without clinical findings or immunological response to gas intelligence, usually do not need to be identified or treated with antibiotics. Secondary prophylaxis. Secondary prophylaxis is the administration of antibiotics to people with the history of rheumatic fever to prevent gas infection, subsequent rheumatic fever recurrence, and to minimize progression to rheumatic heart disease. Secondary prophylaxis is done by benzathine penicillin. It is given intramuscular after every 4 weeks, or it can be given oral. And you can see it is the category duration after last attack. Category is rheumatic fever with carditis and residual heart disease, persistent valvular disease. In this case, 10 years or until 40 years of the age, whichever is longer, sometimes lifelong prophylaxis is given. Then the second category is rheumatic fever with carditis, but no residual heart disease, no valvular disease, 10 years or until 21 years of age, whichever is longer. And the rheumatic fever without carditis, 5 years or until 21 years of age, whichever is longer. So WHO 2002 criteria for secondary prophylaxis patient with proven carditis for 5 years after the last attack or until 18 years of age, whichever is long. Patient with carditis, mild mitral regurgitation, healed carditis for 10 years after the last attack or at least until 25 years of age, whichever is longer. Then more severe valvular disease, lifelong, and after valve surgery, lifelong secondary prophylaxis is given to them. Prognosis. Rheumatic fever can recur whenever the individual experiences new GBH streptococcal infection, if not on prophylactic medicines. Good prognosis for older age group and if no carditis during the initial attack. Bad prognosis for younger children and those with carditis with valvular lesions. So you can see the primary and secondary prevention. First, the streptococcal pharyngitis, it leads to acute rheumatic fever and it further leads to rheumatic heart disease. So the primary prevention is to immediately treat the pharyngitis and secondary prevention is given to avoid the damage of the heart. The provision of catheter-based and valve surgery to prevent morbidity and mortality from cardiac damage that has resulted from acute rheumatic fever, reduced morbidity, financial burden, infective endocarditis prophylaxis, prosthesis, valve disease, and lifelong anticoagulation. So rheumatic heart disease is a major cause of morbidity and mortality in low and middle income countries and among underprivileged communities in high income countries. Primary prevention of acute rheumatic fever requires adequate antibiotic treatment of streptococcal throat infections. Secondary prevention entails prevention of recurrent episodes of acute rheumatic fever and is the most effective way of preventing rheumatic heart disease. Corticosteroids do not reduce the risk of developing heart valve disease after 1 year. Surgery may be a life-saving measure in patients with acute rheumatic fever and major valve lesions. So the summary is rheumatic fever is a more of a clinical diagnosis, but nowadays echo and Doppler also has a role. No gold standard diagnostic test, no entity has rheumatic myocarditis. Duration of prophylaxis depends upon the higher risk factors. Injectable penicillin is better than oral penicillin. School and community-based programs required for primary prophylaxis. Now moving towards the recent updates. It is a WHO document on the rheumatic heart disease, and they have emphasized on it that rheumatic heart disease can be prevented by preventing streptococcal infections, treating them with the antibiotic when they do occur. And it is one of the document on the rheumatic fever and rheumatic heart by WHO. And the barriers to progress is the main barrier to prevention, control, and elimination of rheumatic heart disease are the neglect of rheumatic fever and rheumatic heart disease in national health policies and budgets in countries in which rheumatic heart disease is endemic. The paucity of data to enable targeting the prevention efforts, poor primary and secondary prevention, and access to primary health care, inadequate number and training of health workers at all levels, limited understanding of rheumatic fever or rheumatic heart disease is affected in affected communities, and inaction on the social determinants of the disease and inequities in health. Although further research in some areas is needed, it is proposed that the biggest gap in control of rheumatic heart disease is in implementing effective primary and secondary preventive measures. Again, on the article on the CDC, they have again said the early diagnosis and these infection treatments with antibiotics are key to prevent the rheumatic fever and later on rheumatic heart disease. These are the 2020 Australian guidelines for prevention, diagnosis, and management of acute rheumatic fever and rheumatic heart disease, and these guidelines are available on their website. Now, moving towards the multiple choice questions. Non-communicable diseases are also known as chronic disease as they are not passed from person to person. They are of long duration, generally slow in progression, and occur from a combination of genetic, physiological, environmental, and behavior factors. Commonest non-communicable disease in young children 5 to 15 years age is asthma, cystic fibrosis, rheumatic heart disease, and congenital heart disease.
C.
Yes, C is the correct answer, rheumatic heart disease. A 9-year-old girl presented in Pete's OPD for the checkup of her presenting complaints. Doctors on duty after taking history as a high suspicion of rheumatic fever in that girl. Which of the following is usually the first symptom of rheumatic fever? Chest pain or palpitations, jerky uncontrolled movements, joint pains and fever, rash.
C.
Yes, C is the correct answer, joint pains and fever. Rheumatic fever is inflammation of the joints, heart, skin, and nervous system that occurs in children as a complication of untreated streptococcal infection of the throat. While most people with rheumatic fever recover, which part of the body may be permanently damaged in a small percentage of people? Digestive tract, ears, heart, lung.
Lungs.
No. The correct answer is heart.
C.
Heart. Pericarditis, I have told you, and everything. Aortic regurg, mitral regurg. So it's the heart which is affected. Rheumatic fever is a disease which affects heart, brain, skin, and joints. Rheumatic fever can develop if throat infections are not properly treated. Antibiotics are key to treatment and prevention of rheumatic fever, as strong correlation of rheumatic fever has been established with Staphylococci, group A streptococci, group B streptococci, group A and B streptococci.
C. Group A.
It's B group A streptococci, gas. Remember it with this, group A streptococci. For the treatment of streptococcal throat, penicillin is recommended as treatment of choice because of cost, narrow spectrum of activity, and effectiveness. To avoid occurrence of acute rheumatic fever after streptococcal pharyngitis, penicillin should be given for 5 days, 10 days, 14 days, 28 days.
In 10 days.
B.
Yes, for 10 days. The symptoms, as the penicillin starts, the symptoms settle usually within 24 hours or 48 hours, but one has to complete the 10 days course of the penicillin. This is the point to remember, 10 days. For individuals diagnosed with acute rheumatic fever, the recommended treatment to prevent recurrence and development of rheumatic heart disease and benzathine penicillin G for secondary prophylaxis is administered as an intramuscular injection every 1 week, 2 weeks, 4 weeks, 6 weeks.
C.
Yes, the correct answer is C, 4 weeks. The point to remember is that when someone gets infection of the throat, then the penicillin should be given for 10 days. It makes sure just engrave this figure in your mind. And for the secondary prophylaxis, it is given 4 weekly, and depending upon the risk factors, the duration sometimes lifelong, sometimes for 5 years, 10 years, 15 years, but it's given after every 4 weeks. The goals of treatment for rheumatic fever are to destroy group A streptococcal bacteria, relieve symptoms, control inflammation, and prevent recurrence. Each of the following drug is used to treat rheumatic fever in children except metoclopramide, antibiotics, anti-inflammatory drugs, and corticosteroids.
A.
Yes, the correct answer is A. It is not used in the treatment of RF. There is no single test used to diagnose rheumatic fever. Doctors look for signs of illness and different tests. One of the tests that doesn't predict neither complications will occur nor predicts the type and severity, but its elevated levels may be used to help the confirm diagnosis of rheumatic fever. Alpha 1 antitrypsin, rheumatoid factor, antistreptolysin O, or creatinine kinase.
C.
Yes, the correct answer is antistreptolysin O. The Jones criteria for diagnosis acute rheumatic fever is of fundamental importance. It has different major and minor criteria. Which of the following is one of the Jones major criteria? Pancarditis fever, elevated ESR, or previous rheumatic fever?
Pancreatitis.
Yes, the correct answer is pancreatitis. In hospital ward, a patient with rheumatic fever comes with dancing movements characterized by irregular involuntary movements of muscle groups in various parts of the body. How can you explain this movement? Myopathy, neuromuscular junction disease, Sydenham's chorea, and psychosis.
C.
Sydenham's chorea.
C is the correct answer. This is my key. These are the references. And thank you so much.
Thank you very much. A wonderful presentation, very colorful as well as very informative, and important points that have been discussed in this presentation are worth noting. We are facing the double burden of the disease because both communicable and non-communicable diseases, they are on the rise in Pakistan. And the most alarming thing is that some of the infectious diseases that have the very strong etiology and cause linked with viruses, bacteria, and fungal infections. They are also leading to the non-communicable diseases. And with time, we are coming up with this notion that most of the non-communicable diseases have some type of the etiology that is still linked with the infectious diseases. And infectious diseases, despite of our all efforts in production of more antibiotics, antivirals, antifungals, and immune boosters, immune modulating drugs, still a lot more has to be done. And one of such a scenario is presented by Dr. Sadia very well, that we are still facing rheumatic heart disease and many manifestations like erythema marginatum, arthritis, and other things that can be highly preventable, and something that is preventable and still the prevention is not being done. So a lot more has to be placed in our policies, guidelines, as well as in our health systems. Whenever we talk about the communities, we always talk about the communities of care and how they can be better trained to provide rehabilitation, disability limitation. And the most important part is the screening for these problems. And I see what the minds know. So our mind is much more, has to be trained to pick all these symptoms, especially that are associated with the highly preventable diseases. Very well done, Dr.